Hey, Susan.
Good morning.
Thanks for doing this. We're looking forward
Absolutely.
We're going to wait for just a few, maybe one more minute because the attendees all sort of connect in after we open it up. So we'll give that another minute. All right, people are still coming in, but I'll get started. On behalf of my co-lead for this group, Ken Mayer, and our colleague Alberto Ottoboni, welcome to the Antiretrovirals for Prevention seminar today. My name is Patrick Sullivan at Emory University, and I get the pleasure and the privilege of introducing our speaker for today. Before I do that, I just want to remind people that, there is a chat or Q&A, a chat box that's available to you. And if you can please post questions in the chat, we'll have about 10 minutes at the end, and Ken will be moderating a question and answer session. But it really helps us make the most of that time if people can pop in questions as they occur to you. So with that, it's my pleasure to introduce a physician and a scholar and a great colleague, Susan Little, who's a professor of medicine in the Division of Infectious Diseases and Global Public Health at UCSD. Dr. Little is the co-director of the UCSD Antiretroviral Research Center, the director of the San Diego CFAR EHE Scientific Working Group, and the clinical research site leader for the UCSD ACTG site. Since joining UCSD's faculty in 1993, she's developed one of the leading and most productive NIAID-sponsored programs in the US for the identification, enrollment, and evaluation of treatment of people with acute and recent HIV-1 infection. The San Diego Primary Infection Resource Consortium is that project. And Dr. Little's current research is focused on the use of molecular epidemiologic methods to infer and characterize HIV transmission networks and the potential of prevention and treatment interventions to reduce incidence within those networks. As we put up the slides, I'll thank Dr. Little again for joining and introduce her talk, Understanding Incident Transmission Dynamics and Ending the HIV Epidemic. Welcome, Dr. Little.
Thank you. Thank you. Let's see, go to here. There. Hopefully you've got the slides up. Again, thank you. I'm going to minimize you guys there. It's my distinct pleasure to present today on understanding incident transmission dynamics and ending the HIV epidemic. There we go. Disclosures. I've received institutional support from Gilead Sciences. So everyone has seen this slide 1,000 times, but just to emphasize, the overarching goal of the Ending the Epidemic initiative is to reduce incident infections, new infections by 75% in 5 years and 90% in 10 years, using, among others, strategies around diagnosing, treating, preventing, and responding to HIV infections. So how do we measure incidence in the context of ending the epidemic? Well, first of all, ending the epidemic efforts are local. So federal funding and regional strategies that consider local epidemiology and social context are expected to result in decreases in HIV incidence. And to assess the EHE prevention intervention efficacy, reliable, accurate, and timely methods to monitor incidence are needed. So really, we must be able to detect shifts in incidence on a local level in a timely manner within, ideally, 18 months, not 3 to 5 years. And I'll get to why that's relevant over the next few slides. So from a policy standpoint, that's why incidence is important. How about from a clinical standpoint? So again, we've all seen this. What is the rate of transmission per 100 person years here across the continuum of HIV care? Individuals with acute infection who are unaware of their status are associated with the highest rate of HIV transmission, 16.1 transmissions per 100 person years, with here an overall lower rate of the percentage of overall transmissions at 4%, though that percentage varies widely across different publications. And as you can see at the bottom, part of the reason for that variability across different publications is that the rate of transmission is highly sensitive to rates of partner concurrency, rates of sequential partner switching, and risk volatility, so seasons of risk. So today, I'm going to talk about finding people with incident infection, estimating HIV incidence, and then the impact of incident infection on transmission dynamics. So first, finding people with incident infection. So this is the recommended laboratory HIV testing algorithm. And using this algorithm, people who present who are antigen positive, antibody negative, will ultimately end up down here and be qualitatively viremic and be diagnosed with acute HIV infection. So in terms of measuring HIV incidence, both individual and population-based testing, and I'm going to limit this to the United States. And first, just for everyone, incidence measures the number of infections during a specified period of time, typically a year. So we've got individual measures, acute infection. For the purpose of this talk, I'm always going to be referring to seronegative infection, so antigen positive, antibody negative. So acute infection status based on the laboratory testing algorithm that I just showed. However, one of the challenges is that even when individuals are identified with acute infection, that status, acute infection, is not universally reported. So people are reported as being HIV infected, though that acute infection status is not universally reported and doesn't always reach the public health service. Stage 0, which is a documented negative test within 6 months of a first positive test. Again, knowledge of stage 0 requires reporting of negative test results, which again is not universally, I would say, is arguably rarely reported within the public health system. And then there are population-based tests, estimates. So based on National HIV Surveillance System data, in the US, this estimate is calculated using the first CD4 test after HIV diagnosis and a CD4 depletion model, which indicates disease progression. And we're going to talk a great deal more about that in the course of this presentation. But one of the challenges with measuring HIV incidence is that there are reporting delays. So the CDC recommends, because of these reporting delays, allowing a 12-month reporting delay before including data in trend analyses. So this is what gives rise to that big delay that I talked about a few slides ago in terms of our estimates of incidence within the United States, and why we need better methods to sort of shorten that delay before we have accurate regional estimates of incidence. So again, everyone's seen this, but just to illustrate the CD4 depletion model, this is the national estimate of HIV incidence, illustrating that new infections fell 8% between 2015 and 19 after a period of general stability. And then the dashed line, dotted line also illustrates the ending the epidemic target of 90% decline by the year 2030. So I'm going to talk a lot about our local experience. So as Patrick mentioned in the introduction, the Primary Infection Resource Consortium is a now 25-year program that has been funded by the NIH. And the focus has always been on the identification and evaluation of individuals with acute and recent HIV infection. So in its most current iteration, it is a community-based sexual health clinic that provides diagnostic testing that differentiates acute, recent, and prevalent HIV infection. Individuals who test negative are provided immediate PrEP with linkage to care and mHealth adherence strategies. Point of care STI testing is part of the universal testing package with gonorrhea, chlamydia testing, and what we call text and treat. So people are provided what I call near care, so 90-minute turnaround. So they get texted their test results and if positive are brought in ideally the same day for treatment. So very integrated service delivery. Everyone is offered, everyone who tests positive is offered observational follow-up and specimen banking. And since the beginning of the program, we have recommended antiretroviral therapy for everyone with acute, early, and established infection. We only follow those who are identified who are treatment naive, and I'll get to the importance of that later. And we've been providing Rapid ART at no charge to our study participants since 2014. And then we require linkage to primary HIV care for all study participants because, of course, other than just antiretroviral therapy, people need primary HIV care. So just because I'm very proud of our testing program, I wanted to show you what it looks like. This is the Good to Go clinic. It is an off-site location that is not branded as a UCSD program, primarily because we wanted people not to be deterred by the idea that this was a hospital clinic. So this is a very, I think, user-friendly program, heavily modeled after the Dean Street Clinic in the UK, so I want to give them credit. With separate pods where counseling and testing can take place. So this is our PERC early test algorithm, as we call it. So individuals enter the program, they get a point of care INSTI 60-second turnaround rapid test. If they are rapid test negative, they're offered immediate PrEP same day. If they are eligible, which the vast majority are. I should mention that this clinic is highly focused on recruiting high-risk men who have sex with men and transgender women. So they initiate same-day PrEP if they are eligible. And everyone, I should say, who tests HIV negative reflexes automatically to a qualitative NAT, which also detects, in addition to HIV RNA, HCV RNA and HBV DNA. So PrEP is continued if this is verified as negative. If they test positive by rapid test, they undergo a second immediate different rapid test. And if both are positive, they are offered same day Rapid ART, again, confirming continuing only if positive. We still perform an HIV Western blot, and that's part of our staging algorithm, but everyone also undergoes a quantitative HIV RNA based on samples that are banked at baseline. And then for the rare individual that has a discordant positive first test and negative second test, they reflex back here to the qualitative NAT. Everyone who tests positive and has a positive HIV RNA is confirmed positive, undergoes recency testing. The type of recency test has changed over the years, but in general, these are recency assays which discriminate recent from established HIV infection using one or more biomarkers, using patterns of immune response maturation following incident HIV infection. So the Rapid ART cohort is a clinic-based cohort of consecutive patients with newly diagnosed HIV, including acute and early, also known as recent. These are individuals who have confirmed recent infection based on the recency assay and established or chronic infection with any CD4 cell count. And the intervention, the modified RAPID program, and I call it that because it's based off of a modification of the RAPID ART program designed by Chris Pilcher and colleagues in San Francisco. Individuals are provided access to an HIV provider within 24 to 48 hours of their HIV diagnosis. Same day medical visit lasting 2 to 4 hours. We try very hard to get on this end, 2 hours, which is the vast majority of our clients. Safety and clinical care labs, as I mentioned, since 2014, up here, ART is provided either an INSTI, an Elvitegravir or Bictegravir-based regimen for the entirety of the program. We do provide an observed first dose in the clinic, follow up within 7 days to review labs, either in person or on the phone, depending on the availability of the participant, review adherence, and then case management, insurance assessment, linkage to care, linkage to social services as needed. And ART is provided in collaboration with Gilead contracts, as noted. So this is a summary of just the individuals who have participated in the Rapid ART program who had acute and early HIV infection. So this study has now been published by Tom Martin in our group, but I wanted to highlight these data because these were sort of what I thought a supplement to the available data on the field of rapid ART. There we go. So overall, there were 84 individuals who were included in this analysis, and here is the intention to treat analysis, the rapid ART per protocol analysis, and then finally the rapid ART protocol per protocol limited just to those individuals who started ART during acute seronegative infection. So starting here, the 84 individuals who started rapid ART, they are predominantly male, predominantly Hispanic, and white non-Hispanic. And by definition, they all had acute and early infection. So 60% were early, recently infected, and 40% joined the study with acute seronegative infection. So starting here, 81 out of 84 started ART, so 96.4%. The days from estimated date of infection, I'll use this abbreviation throughout this talk, days from estimated date of infection to ART initiation was, median was 70, with the range shown. And then days from enrollment, that signing informed consent, to ART start was 0, median, with a range of 0 to 5. And then here's what we really care about, sort of rate of viral suppression, less than 50 or non-detectable at weeks 12, 24, and 48. And the rates here were 67-ish%, 82, and 88%. And then not surprisingly, if you jump over here to the per protocol analysis, this gets better after we censor people who dropped out or were lost to follow-up. 75%, 91%, and 98%. And then finally, among those who had acute HIV infection, this increases even further to 84, 92, and 100%. And I should mention the baseline or entry viral load was 5.1 logs for these two groups and 5.7 for this group. So these folks have very high viral loads at study entry when they're starting ART. So overall, the results of this study, antiretroviral rapid ART was widely acceptable among 96.4% of participants who started ART. They started ART a mean of 4 days from disclosure of HIV diagnosis. So that's from the day they found out they had an HIV diagnosis, since it takes a couple of days after the qualitative NAT is performed to disclose to participants their test results. 34.5% started within 2 days of their diagnosis, 69% within 7 days, and the remainder within 60 days. The rapid ART was effective based on our intention to treat study. The mean time from estimated date of infection, not from diagnosis, from estimated date of infection, and I should mention, we do estimate our date of infection based on serologic and virologic data, not based on symptoms. To viral suppression was 15.3 weeks. The mean time from ART start to viral suppression, 7.5 weeks. And the proportion with viral suppression by 12, 24, and 48 weeks, 58, 79, and 88%. And notably, in the 58 people with HIV who started ART less than 7 days after diagnosis, they had even higher rates of viral suppression, 67, 90, and 98% at 12, 24, and 48 weeks, respectively. And finally, this was broadly applicable, as with data that have been reported out of San Francisco across all individuals who start ART. In this group starting ART during acute and early infection, there was no association between starting ART within 7 days and age, race, ethnicity, household income, substance use, or homelessness. And there were substantial contributions, individuals who had low household income, substance use, and homelessness in this cohort. So just to sort of throw up a slide that I borrowed from Clinical Options, I think most people are aware now of the improved clinical outcomes with rapid ART. So this is a systematic review of rapid ART, including the 4 randomized controlled trials. really just showing that same-day ART in all individuals is associated with an increased likelihood of ART initiation, retention and care, and viral suppression, a decreased likelihood of loss to follow-up and death. And in addition, earlier ART initiation reduces the viral reservoir in the individual. And now, treating individuals with acute and early HIV infection with rapid ART, I think that we can say that rapid ART has great potential to interrupt transmissions during this period of extremely high viremia in this patient population during acute and early HIV infection. So now that we've found people with incident infection, and there are different strategies, this was our strategy. How do we estimate HIV incidence, both in regional incidence and national incidence? So the methods to measure population HIV incidence, there are prospective cohort studies, which involve longitudinal follow-up of seronegative cohorts with frequent retesting to identify incident infections. These are logistically and arguably ethically challenging, as well as very costly, and they take a long time. Serial prevalence studies involve measuring 2 cross-sectional age distributions of prevalence and estimating incidence, as long as you also have knowledge of mortality rates and migration. Again, logistically challenging, and they take a long time to complete. Recency assays used, as I mentioned earlier, to estimate HIV incidence alone or as part of a recent infection testing algorithm. These assays to date, none are FDA approved, and they're really right now restricted to research use only applications. And additional validation is needed, I think, to figure out how to use these studies and apply them to public health prevention uses. And then finally, mathematical models. So mathematical models really require reliable prevalence data and some assumptions about survival after infection. And so for the US, the most common, I would argue, almost the only model that is used to estimate population incidence in the public health domain is the CD4 depletion model. And this is, as I said, currently used by the CDC, both regionally and nationally, and we're going to talk a great deal more about this model. So how did the CD4 depletion model, how was it developed? So we're going to go kind of through the stages of development. It's a fairly complex model. So it began with some observations by Sarah Lodi and colleagues looking at the rate of CD4 decline pre-combination ART. So Sarah looked at the rate of CD4 decline, which was compared between a seroconverter and a seroprevalent group or cohort of individuals. So the seroconverter, about 7,000 individuals were pulled from the Cascade cohort, which is this Cascade cohort is a cohort of about 25 different cohorts of individuals with well-documented seroconversion from Europe, Australia, Canada, Africa. The seroprevalent group was the Concord trial, which was a randomized controlled trial of immediate versus deferred zidovudine treatment. And in the trial, there was no difference in the 3-year rate of progression to AIDS or death between the 2 treatment groups, and there was minimal transient effect on CD4 cell count. So the seroprevalent Concord trial, the Concord trial was thought to be a good group to evaluate as the seroprevalent comparator group. So what you can see on the left then is a linear mixed model of CD4 on square root comparison of the seroconverter group in the top solid line without individuals with acute infection, the seroprevalent group on the bottom solid line, shown here in their years, their CD4 decline over years since date of seroconversion or randomization in the case of the Concord trial. But notably, the rate of CD4 decline among the seroconverters here in the middle was different. So the rate of CD4 decline among the seroconverters without HIV, without acute HIV was not different from those with seroprevalent infection. However, the CD4 decline was faster among the 4% with acute HIV infection in this study. And that was thought to be due to the fact that the group with acute infection, this was probably a proxy for those that had symptomatic seroconversion, which we know is a marker of more rapid disease progression. So CD4 decline, and the conclusion of this study was that CD4 decline measured in the seroprevalent group can likely be used to generalize to the entire population, that is all but those with acute HIV infection. So now we move to the next step in the CD4 depletion model, the diagnosis delay. So the time between infection and diagnosis, which is the diagnosis delay, had never been measured. So in these sort of combination of two studies, Irene Hall and Song and colleagues, the time between infection and diagnosis was measured using CDC National HIV Surveillance System data between 2003 and 11. And what they did here is they used the results of the first CD4 test after diagnosis and that CD4 depletion model that Sarah Lodi developed to estimate the diagnosis delay. So here's the CD4 depletion model. And what they do is you take an individual whose first CD4 cell test after diagnosis, in this case is 210. They are diagnosed in 2010 and projecting back from, it's more complicated than this, but projecting back off of the CD4 depletion model, it can be estimated that this person was actually infected back in 2002, 8 years ago. So this is how the diagnosis delay was measured. So now, how do you use all of these data to estimate incidence? So again, people diagnosed between 2006 and 13 now, and their first CD4 test results at diagnosis were used to estimate now the distribution of diagnosis delay from HIV infection to diagnosis based on this CD4 depletion model. And then weights were assigned to account for a whole variety of things, reporting delays, missing CD4 data, sex, race, ethnicity, transmission category, age at diagnosis, and end of study status, whether you were living with HIV without AIDS, dead without AIDS, or had AIDS, living or dead at the end of the study. And then this distribution was used to estimate HIV incidence, prevalence, and the number of undiagnosed infections. And this is the model still used today. Some of the challenges, however, with this model is that increased testing is expected to overestimate the diagnosis delay and could result in an overestimation of incidence because of model assumptions, which I'll try and review here. So issues with the model assumption. So starting with the initial CD4 drop associated with acute infection, this will cause an overestimation of the time since infection. So we all know this trajectory, this natural history curve of HIV natural history. So during acute infection, this is the CD4 curve in blue, there's a transient drop in CD4 cell count in most individuals. And so what happens here is if someone is diagnosed right here, during peak viremia, perhaps during symptomatic acute infection, and a lower CD4 cell count, let's call it 500. That first CD4 cell count will be read out. This is not the CD4 depletion model, but let's pretend that the CD4 depletion model is here. It will be read out over here because this transient drop is not included in the CD4 depletion model. So this individual will be read out as having a longer duration of infection than they actually have, not weeks, but rather several years worth of infection. So that will result in an overestimation of the time since infection. Next, the distribution of diagnosis delay is estimated using standing survival analysis techniques for right truncated data, which assumes a stable diagnosis delay. Although the model assumes a stable diagnosis delay, the authors acknowledge that during the course of the study to determine, this diagnosis delay distribution, the diagnosis delay actually decreased. from 7 to 5.6 years, most likely as a result of more widespread testing. So as testing becomes more widespread and people are diagnosed earlier, the first CD4 cell count becomes higher over time. So during the course of this study, the diagnosis delay decreased from 7 to 5.6, and the first CD4 cell count increased. So they acknowledge that this is a challenge with the model, but again, the model assumes a stable diagnosis delay. So again, these assumptions become problematic in the setting of rollout of ending the epidemic prevention interventions, which we hope and expect will shorten the diagnosis delay. So this is one of the big challenges of the CD4 model assumptions, which wouldn't be problematic if we weren't actively doing everything we can in the setting of ending the epidemic prevention interventions to shorten that diagnosis delay. So we decided to do a simulation study to test some of these model assumptions associated with the CD4 depletion model. And this is a study that has not yet been published. We hope will be soon. It's under review. Michael Tang and our group took the lead on this study. This is a simulation study to investigate the impact of 2 epidemic parameters on incidence estimates derived from the CD4 model. So the annual rate of HIV incidence decline was one variable that we modified in the simulations and shown here on the figure. The annual rate of CD4 decline could be stable, so no change over time. It could undergo a slight decline of 5% annually, shown here in red, or a rapid decline, shown as 24% annual rate of decline. And that rate was chosen specifically to achieve the ending the epidemic target goal of a 75% decrease in HIV incidence over 5 years. We also modified, because we know this is a sticking point with the depletion model, we decreased the diagnosis delay in association with theoretical ending the epidemic interventions. So we said there could be no change in the diagnosis delay, which is the current CD4 depletion model, or we could reduce the diagnosis delay by 10%, 25%, or 50% associated with, again, theoretical, widespread, universal HIV testing. And then we compared the incidence estimated by, again, the current CD4 model or the simulated CD4 model with these parameter changes, and looked at the incidence for each scenario. And what you can see here is the outcome. So we chose, just for this figure, an annual rate of HIV incidence decline of 5%, which seems to be concordant with a lot of current large jurisdictions. Plotted over here is the difference in the current CD4 modeled incidence, which has in blue no diagnosis delay. So this is the CD4 modeled incidence versus what we call the CD4 simulated incidence, which includes these variable changes in the parameters. So in this case, the rate of incidence is not changed. It's an annual decline of 5%. And the diagnosis delay is either 10% in green, 25% in red, or 50% in purple. And what you can see is that for an intervention that shortens the diagnosis delay by 50% here in purple, oh, and I should have mentioned the dotted line is the start of the intervention, roughly 2020-ish. For an intervention that shortens the diagnosis delay by 50%, the simulated incidence would require 6 years to approximate out here, would take 6 years to approximate the current CD4 modeled incidence to within 10%. Interventions that shorten the diagnosis delay will cause overestimation of the HIV incidence in the CD4 model. So yes, it's dramatic with a 50% decrease in the diagnosis delay, but even with a diagnosis delay of 10%, so a modest, let's say, intervention that decreases the diagnosis by 10%, you're still going to get an overestimation of HIV incidence using the CD4 depletion model with this change in the diagnosis delay. So what's the impact of incident infection on HIV transmission dynamics? So again, we go back to the Primary Infection Consortium we wanted to evaluate what were the major drivers or predictors of incident transmission in San Diego. So between 1996 and 2018, we identified just over 1,100 newly and previously diagnosed therapy-naive people with HIV who were identified and followed. And therapy-naive is important because, again, we looked at the genetic distance-based network that was inferred using their baseline drug resistance test results, their pulse sequences. And so for that, they were all therapy-naive. We modeled cluster growth and predicted the effect of theoretical prevention interventions. And a comparison was made to the CDC ending the epidemic molecular surveillance strategy. So the cluster detection strategy, which does not incorporate data on incident infections. And our hypothesis was that by prioritizing people with incident infection of less than a year, its duration, versus prevalent infection status, we could improve the yield of priority cluster detection. So this is the, move this down here somewhere. This is the summary of the, up on the top right here, the total 1,100 individuals that were analyzed in this study. And they were divided among three different groups. The primary infection, newly diagnosed individuals, 741. The PERC previously diagnosed and newly entering care, 194. And then the CFAR CNIX cohort, who were also previously diagnosed and newly entering care. And since I'm not really there are some differences across these different studies, but I'm really just, in the interest of time, going to focus on the total here. This is a predominantly male cohort with race ethnicity about 50% white non-Hispanic, 30% Hispanic, predominantly men who have sex with men, and sort of a smattering of some of the other transmission risk groups. Risk data were incompletely collected in this study, but among those who did report risk, 34% reported illicit drug use, 74% reported condomless anal sex, and the median number of sex partners in the month prior to study entry was 2. And then finally focusing on acute, recent, and prevalent status at the time of study entry. 59% had acute or recent infection, and 41% had prevalent or presumed prevalent infection. Everyone in the PERC study had diagnostic testing to verify their prevalent status, except for a small number for whom 20, for whom samples were not available and they were presumed to be prevalent from a conservative standpoint. And everyone who entered our local primary HIV care clinic to establish care was presumed to have prevalent infection. So this was the breakdown. So in terms of cluster detection and response, the analysis, the CDC method prioritizes clusters of minimum of 5 newly diagnosed cases in a high burden jurisdiction, which San Diego is, identified within the previous year, linked using a genetic distance threshold of 0.5% to cases diagnosed in the previous 12 months. So the goal is to use this as a proxy for recent and rapid transmission. So that identifies a cluster worthy of investigation. The UCSD method used the same CDC criteria to prioritize clusters, but liberalized the genetic distance threshold to 1.5%. We compared new incident cases linked to clusters identified by the CDC compared to the UCSD methods during follow-up. And the primary outcome for both was incident cluster growth, which we defined as linkage of an incident node to a node already in the network, incident cluster growth. So this is a schematic of all of the possible cluster outcomes. And I'll start down here with the legend. What we wanted to do was investigate the history of each cluster lineage and go back in time and find the first node individual identified for each cluster lineage before that node was linked to anyone else in the network. And that node we called a seed, marked here by the striped lines. So seeds are the first node in every cluster lineage at the very beginning of our study. Nodes could be prevalent, marked in blue, incident, infected for less than a year, marked in red, and the event is an incident cluster growth event. So the linkage of an incident node to a node already in the network. So what you can see is that there were about 750 nodes, seeds, that began as singletons, 268 as prevalent nodes, and 319 as incident nodes, that throughout the entire duration of the study, people were followed for years to up to 20, the longest follow-up I think was about 10 years, that began as singletons, meaning not linked to anyone else, and ended as singletons, not linked to anyone else. Then there were 18 nodes that began as dyads and 54 nodes that began as singletons, that these nodes did not acquire any new nodes during follow-up. These 54 nodes acquired only prevalent nodes during follow-up. So finally, the cluster lineages that we care the most about are this one, which is a single dyad that acquired one or more, in this case, incident node during follow-up. And these 91 nodes that acquired both prevalent and incident nodes during follow-up, ending up with 91 clusters ranging in size from 2 to 23. So, back up there. Worth noting, there were 117 incident-to-incident linkage events, which comprised 54% of all linkage events within 56 clusters. The median time between the estimated date of infection of what we call putative transmission pairs, because we're not proving direct transmission, was 2.6 months. So if we identify an incident node and then a linked subsequent incident node, incident cluster growth, the time between the estimated dates of infection of those two individuals was 2.6 months. So there is very little time to interrupt transmission after the identification of the first individual with incident infection. So again, what are the drivers of cluster growth? We studied here, looking at the hazard ratios primarily, the proportion of individuals in the cluster with incident infection was the major driver of incident cluster growth, as evidenced by the fact that these individuals transmit very rapidly in association with their very high viral loads. Cluster size was a predictor, positive predictor, and clusters start pre-2005. And the reason 2005 was picked was because the number of incident infections diagnosed was increasing prior to 2005, and after 2005 it was relatively stable. So we chose that as a bifurcation mark. In terms of the proportion of unsuppressed individuals, there was a trend towards this being positively associated, though it was more significantly associated in the univariable model. The proportion of individuals of Hispanic ethnicity was negatively associated with incident cluster growth, as was the median age of individuals in the cluster. And finally, the median number of sex partners of people in the cluster was not associated with cluster growth. So in terms of looking now at priority cluster detection, so if we took this entire inferred network and applied the CDC method using the 0.5% genetic distance, we identified 116 clusters. And of those, how many would be triggered or flagged for further investigation? A total of 3 were flagged, and the arrow marks the time at which they would be flagged. And after flagging these 3 clusters, and then following them over time, a total of 11 linked incident infections would have been, these red dots, would have been identified in association with just this one cluster over the next 1.2 years. Now, if you compare that to what I call the UCSD method, where we liberalized the genetic distance, so not surprisingly, more clusters identified, 155 clusters. a total of 4 clusters would have been flagged as marked by these arrows, the point in time when they would have been flagged. With this method, 24 linked incident infections would have been identified over the next 4.4 years in association with all 4 of these clusters, flagged clusters. And you can see the number of these red dots appearing over time. But again, the majority of them are occurring in these 2 clusters, 1 and 4, and they're quite closely associated with the point at which that cluster is flagged. So next, we wanted to look at the impact of, again, potential interventions on the predicted incident cluster growth. So first, this is a model that looked at the number of newly linked incident cases per cluster, first looking at no intervention at all. So the natural history of incident cluster growth over time, in this case 3 years, was to increase to the point that after 3 years, we would see 0.17 incident cases per cluster after 3 years. So that's generalized over the entire network. So as you saw before, most nodes don't acquire subsequent incident cases. So when you generalize it, the rate per cluster is quite low. But if we then go to look at an intervention that prioritizes individual, if we then go back and try and prioritize individuals with incident infection, for reference, on each of these figures, the red line is the no intervention line model. And then we look at an intervention that reduces the number of individuals or transmissions by 50%, proportion of transmissions by 50%, or 75%. What you can see is a dramatic decrease in the number of incident infections per cluster. So call it 60% overall, regardless of whether you're talking a 50 or a 75% reduction in the proportion of incident infections based on that intervention. So how about if we look at an intervention that reduces the proportion of unsuppressed? So again, red is the no intervention. If we look at an intervention, a theoretical intervention that reduces the proportion suppressed by 50 or 75%, you really see a very modest effect on the reduction in the number of newly linked incident cases per cluster. And then finally, we did a combination intervention on both the proportion unsuppressed and incident infected, no intervention compared to a 75% reduction of both. And again, a rather dramatic reduction in the number of incident cases per cluster, but again, not much different than what we saw with just the intervention isolated to just those with incident infection. So again, the challenge here, though, sounds great, but the challenge now, I would argue, is to identify and intervene in persons with incident infection in a rapid enough manner to prevent transmissions, given the estimated time between the estimated date of infection of putative transmission pairs of 2.6 months. So transmissions from incident infection happens very rapidly. So if you're going to intervene particularly if you're going to focus your intervention on individuals with incident infection, you need to intervene very rapidly. So conclusions from this study: over the past 2 decades, move fast, Susan. Over the past 2 decades, incident infections drove incident cluster growth in San Diego. Total cluster growth is not a reliable proxy for incident cluster growth. The current CDC ending the epidemic cluster detection and response strategy would not have identified most transmission events arising from those with incident infection in San Diego. And interventions such as Rapid ART prioritized incident cases and their newly diagnosed infected contacts, and PrEP to uninfected contacts are likely to limit ongoing transmissions. But I would argue, I keep using the word incident infections. We can identify people with acute HIV, but we can't routinely identify people with recent HIV. And this kind of intervention for people with recent infection requires that we really treat all new HIV diagnosis as if they were recently infected, since we can't tell who's recent and who's established, if you want to try and interrupt some of these recent rapid transmissions. And finally, molecular surveillance that includes detection of incident cases, if we could do such a thing, will allow direct measurement of the impact of interventions designed to reduce incidence. And I just wanted to end with a couple of slides that brings us to sort of where we are now. So as part of a collaboration with the San Diego Public Health Department, as part of a HRSA contract, we are analyzing molecular surveillance data in near real time to identify growing clusters. And the cluster analysis includes lots of metadata, demographics, transmission risk. The only variable that is, all of this is de-identified except zip code, which is PHI. Our goal is to improve our estimation of true HIV incidence in San Diego County using epidemic simulation modeling that integrates molecular data. We're working with our study community advisory board as well as the general community to develop and evaluate potential interventions to reduce transmission. And we want to be able to predict future incidents to determine whether we're on track to meet our EHE targets and assess what interventions scale up and prioritization is required. And so I just wanted to sort of illustrate that using a genetic distance threshold of 1.5% and analyzing all clusters of greater than size 3 in San Diego County, this is what our cluster detection looks like. And so we've categorized cluster growth as fast, slow, and stagnant using a separation that characterizes, we take the number of cases added to a cluster divided by, in the last 12 months, divided by the square root of cluster size, which normalizes cluster growth to cluster size. And if that number is greater than 1, it is a fast growing cluster. If it is less than 1, it's a slow growing cluster. And if that's 0, it's stagnant. Clustering rate back. If the, go forward, sorry. There we go. Clustering rate is shown by the green density, and then cluster size is shown by the size of the circle. And what you can see is we have a lot of circles here in San Diego of some quite large size, and really to hone in on the area of interest, the rapidly growing clusters in blue. So we have a lot of rapidly growing clusters. And this, what our emphasis right now is on focusing on those clusters that have been rapidly growing just in the last couple of years. And that's what we're going to try and prioritize. But that still includes, if you limit rapidly growing clusters to the last year and a half, that's still hundreds of individuals who are involved in these rapidly growing clusters. So finally, last slide, to assess the efficacy of ending the epidemic, prevention interventions, reliable, accurate, and timely methods to monitor regional population incidents are needed. Timely and universal reporting of individual measures of incidence will inform population estimates of HIV incidence. And I encourage everyone to try and look into how they can add these individual measures to their local population estimates. Prevention interventions that lead to a shortened diagnosis delay will cause an overestimation of regional HIV incidence using the CD4 depletion model, which is the model widely used everywhere by public health departments. Molecular surveillance that includes detection of incident cases will provide a more effective strategy for prioritizing EHE resources, because you want to know where transmission is happening now. To try and interrupt further transmission, detecting prevalent cases is incredibly important. But if you want to stop transmissions, you need to detect incident cases. And then finally, the current CDC EHE cluster detection response strategy would not have identified most transmission events arising from those with incident infection in San Diego. And I would argue that more liberal genetic distance thresholds, 1.5%, may be appropriate for jurisdictions with the resources to deploy appropriate response strategies. And I really, this is the work of many individuals in our group, most of whom I've already thanked, but we have ongoing programs with multiple health departments, and the others are mentioned here, so I won't name everybody. And our support, thank you very much. Happy to take questions.
Thank you so much, Susan. That was brilliant and really enlightening. I've got a couple questions, and I know Patrick has one. Have you utilized these techniques now to actually focus on physical venues or virtual venues for these hotspots for transmission clusters?
Not yet. That's one of the goals. I think one of the, I would argue, disconnects is that much of the public health surveillance data that we have does not include, we've got geographic location, but not venue. So, so what we are able to do is take geographic location, which we can narrow pretty much, and then we can feed that back to the public health department, and they can take the data, and if they have venue information, they may be able to localize it. But in general, I think as we get down to sort of being able to refine incidents more and more, I would argue we need exactly what you said. We're going to need more information on new diagnoses, including venue data.
Yeah, that seems like the next frontier. The other question I have is, in some of the previous studies, for example, HB 078, we found a fair amount of occult antiretroviral drug use. And I'm just curious if you're doing any drug testing, because just looking at resistance is not necessarily going to be the whole picture, and people may be cycling on and off ART and may be misperceived in terms of their infection status.
Yeah, absolutely. I know I've had this discussion with Patrick before, because I think there are certainly, I don't want to say I think this is regional, but we have considered it, and to tell the truth, we have not, simply because when we've been doing universal resistance testing for multiple decades now, and the resistance testing has not led us to believe that we've got a lot of any prior antiretroviral treatment use. We probably could do sort of a sentinel study to try and tell that, but we have not. And arguably that would be a limitation of our study.
Okay, I'm going to give you
it's a resource issue.
Thank you. I'm going to give you two more questions. We'll see if we can get them in time. Joanne Steckler says that she's always said that the proportion of transmissions that occur from persons with recent acute infection will vary depending on the proportion of persons with known HIV who are ART suppressed. Could you plan to run the model, simulate location where a lower proportion of persons with established infection are suppressed to show whether transmission infections from persons with incident infection still predominate? And Colleen Kelly has raised the question about some groups being opposed to molecular surveillance because of criminalization laws. So your data certainly suggests that it may not be relevant with the current lag, but do you have questions about those concerns?
So Joanne, I think that's a great question. I actually hadn't considered it. Thank you. We will. And I think that Colleen, yes, I have a whole grant on the ethics of molecular epi, so well aware of this issue. And I think that I guess I don't want to minimize this. I think a lot of the concern around molecular epi has been first around sort of the implementation of field services. So people going out and finding individuals linked to these clusters. And that is part of the reason that we are doing as part of this HRSA study, a community, what we're calling community informed molecular epi. We're trying to actually develop interventions that are acceptable to our local community. But second, I would argue that molecular surveillance has really been transformed into a monitoring tool. So it is really both by the CDC and by people like myself who are using it. We are heavily using it as a monitoring tool to identify places where resources need to be reallocated. And so in that regard, I think we can definitely argue that, we could shift the genetic distance threshold, which I really think is, if the CDC shifted their genetic distance threshold, there are not enough people in the public health sector to intervene on the number of clusters that would be identified. It's just too much. So, so I think the genetic distance threshold is really, there's nothing set in stone that 0.5 is the magic bullet. I think the genetic distance threshold is something that should be malleable and should be relevant to the region and the resources. And in our case, will help us sort of help to both model potential interventions, because it helps us to identify, sort of a much larger potential problem. So I am hopeful that the community will understand that this is really all about identifying and allocating appropriate resources to the community, not about tracking down. And I very carefully always use the word putative transmission. We are not able to identify or prove transmission between one person and another.
Well, Susan, thank you so much. This was a brilliant talk, and we really appreciate you spending time with us. I want to thank everybody for your participation. We have our next session at noon East Coast time on February 6th, and Patrick and colleagues will be talking about some of the exciting work that they've been doing, trying to get estimates of the populations who are PrEP indicated, PrEP utilization, and other related issues, and we'll send more information closer to the time. So again, thank you everyone, and thank you again, Susan Little, for a wonderful talk. Take care.
Thank you.